adolescents, and particularly looking at the gender impacts of the COVID outbreak among adolescent girls in Nairobi County. This meeting this morning is hosted by a partnership led by the Ministry of Health, together with the Kenya National Bureau of Statistics, the National Council for Population and Development, and the Nairobi Metropolitan Services. There are development partners who've been involved in the exercise, the Johns Hopkins University, and funded by the Bill and Melinda Gates Foundation. Steering this exercise is the International Center for Research in Reproductive Health. The International Center for Reproductive Health has conducted the survey in this past quarter in Nairobi, and to present the information this morning, I would like to invite Professor Peter Gishangi, who is the principal investigator and also Deputy Vice Chancellor of the Technical University of Mombasa. I would like to welcome you to listen along, but also to interrogate and see connections between the COVID pandemic outbreak and the delivery of services for youth, particularly the adolescent girls in Nairobi. Welcome, Professor Gishangi.
Thank you. Good morning, everybody. Professor Peter Gishangi is my name. I would like to take you through the findings of the Youth Respondent-Driven Sampling Survey Follow-up and Gender and COVID study conducted in the county of Nairobi in 2019 and 2020. I would like first to acknowledge the International Center for Reproductive Health, the NGO implementing this work, colleagues from Kenyatta University, Johns Hopkins University, Minister of Health, National Council for Population and Development, Kenya National Bureau of Statistics, and the collaboration and the cooperation we have received to date from the participants as well as from the Nairobi Metropolitan Services. So this study, first round was done in 2019. We involved persons aged 15 to 19. We reached about 1,357 persons. We looked at their reproductive health needs and also looked at issues of economic, social, and safety impact in terms of gender-based violence. We have reconducted the persons who participated in 2019 in 2020. What were the objectives of the first round? We wanted to know the percentage of unmarried females and males who know a different form of family planning method, those who were using a family planning method, and what were the sources and consumption patterns for persons aged 15 to 24 years. The second round, we wanted to characterize the changes which has happened over time, what we call determinants since 2019. We also wanted to characterize changes which may have occurred due to COVID-19 outbreak. And here we have looked at gender stratified qualitative analysis and quantitative analysis. These studies, have, first round was face-to-face, second round has been a phone-based survey just because of the restrictions required for us to observe the required regulations. We have reached about 1,223 persons for the YRDS follow-up study and about 1,217 for the gender COVID follow-up study. There are other components which are ongoing, mini survey, and we will be reviewing these persons in 6 months' time to look at what changes could have occurred over that period of time. So we have had focus group discussions, we have had stakeholders, we have had key informants, and we are now going to have in-depth interviews to understand further any issues related to family planning as well as COVID-19. On average, we made about 1.6 attempts to reach a person to respond to the YRDS and about 1.5 times to address, to reach persons for gender COVID follow-up study. We used Swahili, English, and a mix of the two languages, but principally about 79% we used English language for both males and females, for both surveys. Now, in terms of the persons who participated, in 2019, we had 1,357. 1,293 gave us consent for follow-up. about 1223 were available for the follow-up, 68% were lost, and 2 did not agree to participate. For the gender, we had 1217, we lost about 6 persons in a week's time. This is important for us to note that when we are conducting this survey, it was just when the first peak of COVID-19 was going down. That's the box which shows when we did conduct the survey. So these are some of the things I'm going to describe: participants' characteristics, sexual and reproductive health since 2019, any changes which may have occurred therein, challenges in health access, gender and COVID. You're going to look at risk perceptions, autonomy and privacy, economic outcomes and time use. You're going to look at transactional relationship, safety and gender-based violence, and mental health and social support. So these persons, we had about 41% males and 59% females, and you can see the distribution. Majority of them had secondary and college education, with about 11% having attained university education. No differences between males and females. If you look at the main activities before COVID-19, about 11% were employed in the formal economy, with about 31% in informal economy, 38% were students, 12% were self-employed. And we see differences between males and females here. If you look at the living situation, and this is important, about 23% were living alone. We see again gender differences here, where only 6% females were living alone, compared to 48% of the males. So if you look at issues which are pertinent, we have found from 2019 to 2020 is that 28% of the person who reported using a method then were still using a method at this time point. 14% had switched the method, 15% had stopped using, with 28% who had begun to use a method. And this is important to note, that within 1 year period, more than a quarter of the persons who are not using a method started using, and we had about 15% who remained non-users. Characteristic for this population, most of them were using condoms, particularly for males. Remember, there are 4 methods of family planning for males, condom being the most common. Vasectomy could be another one. You can also have abstinence. So those things can happen. But for females, we're using condoms and emergency contraception. If you look at the reasons for switching and discontinuation, which is important, we find that the 3 cardinal reasons. One was concerns about contraception or possession from others. We see medical reasons, and medical reasons were fear of side effects, and others. We see access-related reasons and also partner-related reasons. So as we're looking at how do we address these issues, then we need to look at issue of partner, issue of counseling for medical reasons, and issues of access for both male and female switchers. If you look at contraceptive disruptions, we notice that about 40% of the males and 35% of the females experience difficulties accessing contraceptives. And this is important. Why? Because either the facilities were closed or the doctor was not open. We see that they were unable to access services because of government restrictions on movement, but also the biggest of them all is fear of getting infected with COVID-19 at health facilities. We have just been reassured this morning that in Nairobi and in the entire country, services are available and precautions are in place to ensure that nobody gets infected by going to those facilities. Are there differences by age? Yes. We see 16 to 19, to 20 years, who are the adolescents, that of the 49% who are users, 23% continue to use, 12% switched, and 14% discontinued. But please note that 29% started using a method. If you look at the older persons, which is 21 to 26 years, again, we see a similar pattern. What are some of the preventive behaviors regarding COVID-19? And this is extremely important to note that young men and women do appreciate these interventions. And we see, again, gender differences, washing hands with soap and water. Quite a huge number of them reported, over 91%, washing hands and sanitizer frequently, about 70%. Staying at home, we see that women were more likely to stay at home than men. Avoiding contact with others, we see again there are differences with 79% of the males as compared to 88% of the females. Coughing to one's elbow, avoiding shaking hands, wearing something to cover their mouth and nose. And we also note that a few of us, young people, are engaged in prayer. We see that the changes which have been put in place has required persons to stay at home, and this has consequences in terms of decreased privacy. This is disproportionate for the young women. You can imagine one small room where the parents are there and the young woman has to change her innerwear or something. This has contributed to less privacy being experienced, particularly by young persons, particularly women. We see about 76% compared to 48% in terms of males. What else do we see? A negative economic impact of COVID-19, where we see that 45% of the young men and 53% of the young women were not able to meet their basic needs. And this is several reasons. Either the breadwinner has lost their job, and we have a quote here, you find that a member of the family may be used to work in a certain industry, then due to COVID-19, they have lost their job. So essentially, we see that, yes, a loss of jobs is translating to challenges for the young people. Are there gender differences in terms of access to technology? Yes, and we see that, indeed, if you look at access to internet, always have access to internet, we see 26% of the girls compared to 40% of the boys. Are there gender differences in terms of economic dependency? And we see, yes, there are differences here. We see the young women, 42% were fully dependent, compared to 32% of the girls. So again, these issues of restrictions has affected girls disproportionately more than men, young men. We see here how time is spent since COVID-19, and we see clear differences between young men and young women in terms of the proportionate amount of time spent caregiving, housework, gathering supplies, or even schoolwork. You notice that, yes, the young men spent a little bit more time doing schoolwork as compared to the girls. And that, again, can have impact in terms of what happens thereafter. Now, we already know that there are transactional relationships. Has this changed over time? And we see that 6% of the young men started or continued a sexual relationship or dating in the last 12 months. And this is where there is exchange of money, necessities, or other gifts. And this is important because we see that there are interaction between all those components. But we also noted that there is sex trade. That means exchange of goods, gifts, and necessities outside their regular partnership. And we see that this has increased over time due to COVID-19. For the first 1 year, we wanted to figure out, are there changes in terms of intimate partner violence? This is violence made by somebody who is very close to you. And we see that physical or sexual partner violence in the last 12 months is about 17%. But note, only about 11% were able to seek services due to partner violence. Now, in terms of, has this changed over time? We see that before COVID-19, about 30%. Since COVID-19, we see 43% episodes came after COVID-19, and we see that 27% is both times. So again, we see negative impact of COVID-19 here in terms of intimate partner violence. What is the risk? We see that the risk is changing over time, and as we look at overall in the last 12 months, 16 to 18 years, we see 27% indeed experience something compared to the older persons, 22, 26, only 16%. So these issues are important for us to note that indeed, since COVID-19 has happened, we see that there are indeed increases in terms of the violence related to partners whom you stay with. Now, looking at mental health, we see that we did ask questions about retro interest or pressure in doing things, and what we see that several days, about 38% of the men said, so for several days, they have retro interest or pressure in doing things, compared to 39% of the females. And that is significant. What about feeling down, depressed, or hopeless? What we see here is that, again, for several days, we see 28% of the young men and 34% of the young women indeed reported that they have feeling down, depressed, or hopeless. These are questions which help us to understand, do the patients have any symptoms of mental health? And this has increased over time. But what's the positive side of it? We see that indeed there is support, social support, which exists, because we ask, there is someone in my life I can share my joy and sorrows with. That is part of social support. And a lot of them say it strongly, they agree, almost 40%, both men and women, and agree was nearly 50%. So this is a positive thing. Yes, we have mental health issues, but there is social support. I have someone to count on when things go wrong. And we see again, strongly agree, nearly 50%, and I can get emotional help and support need from people in my life. What we notice that yes, indeed, nearly 50%. So our social support structure still exists to help deal with mental health. So in terms of the next step, what do we see? That over time, we have seen a net gain in contraceptive use among both young men and young women since 2019. That's a positive thing, that the things we are doing as program interventions are bearing fruit, despite the fact that there are challenges with COVID-19. Condom remain the dominant method of contraception for this group, which again is expected. They are looking for contraception for short-term use. If you look at method switching, yes, indeed it is there, and we need to address the issue of medical component, which then you can be able to reduce in terms of young men and young women changing or switching the methods. We know the president pronounced himself regarding the youth, and therefore we need to really work with the youth to again get a sense of purpose and self-esteem so that they can address the challenges they are going to be facing with. We have just seen mental health is a big thing, and we need to be able to address it so that individuals then can be able to overcome these things. We have arrived quotes, which I have not shared here, which shows the different experiences of young men and young women in terms of the different components of economic impact, social impact, negative effects on access and use of family planning, and other general health services. We still remain very concerned about the issue of economic health impact and mental and safety. And we notice here, and I did not show that slide, that indeed young men and young women do dread the encounter with policemen, particularly because of curfew. We see gender differences which exist in the elements we have looked at. And these gender imbalances are important because COVID-19 is amplifying these known gender differences. So young women face substantial economic risks that extend financial dependence on the male partners. We see gender differences in time use and time substitution, where young women are tending to continue to play roles which are defined, home care, caregiving in houses, and for men, income generation. We notice that gender-based differences in terms of risk of violence, where partners are involved, and this is complicated by the fact that more family members are now spending more time in their homes. We see clearly gender asymmetry in terms of mental health and social support, depending on whether you're a girl or a boy. This is a very important slide because without all these partners, then we would not have been able to correct this data, particularly to thank my team here and ICRH with all the support from the country director who is present here and the members of the board, our research assistant, our enumerators, the Johns Hopkins University, JPIGO. We have the economic team which has analyzed this data, as well as colleagues from Kenyatta University. Without this team, we would not have been able to then correct this data we have shared with you. This is very brief summary. More details data are available. Indeed, we have 9 different documents, which each of them is about 5 pages each, examining into greater details each of the domains I've talked about today. I would wish to stop here so that we can engage into the panel discussion, so that then the panelists can tell us from their lenses, how do they see the interpretation of this data. But before I give way to the panel discussion, I would like to encourage you to take out your phones or laptops and send a social media post on the greatest needs affecting youth in Nairobi related to COVID-19. The hashtag is PMA Gender. Please do that, and I think that way we'll be able then to get more and more people to know about what we are talking about today. So thank you very much for listening to me. Thank you.
Professor Gishangi, thank you very much as the principal investigator for sharing these very profound findings that have only been the subject of guesstimates, but for which now we have really certain data, at least for the Nairobi metropolitan region. Now, as you have mentioned, we would like to investigate further what are the policy and program implications for this data that you have just shared with us. Indeed, you have confirmed that there are gender differences, there are security implications, there are economic implications, there is social support implications of the data that you have presented this morning. And now to discuss the implications of these findings, I would like to invite Mr. Sam Mulianga to come and lead a panel discussion so that we can explore what it is really that can be done to put this data into action. Mr. Sam Mulianga, you're welcome.
So as you've heard, I'm Sam Mulianga, working with JAPIGO, which is an affiliate of Johns Hopkins University, and specifically the Advanced Family Planning Initiative. Now, we are glad to have a very good panel here with us. This panel comprises different cadres and personalities that we have. And we are going to have, right at my farthest end, we have Dr. Bernard Onyango from AFIDEP. We are also joined by Gladys Mugambi from the Ministry of Health, working in the area of health promotion as well as COVID-19 matters. We have young people, Brian Otieno from Alfajiri Youth Network here with us. And right here with me, we have Dr. Leah Wanjama from Kenyatta University Center for Gender Studies. So this is going to be an interactive session with our panelists to dive deeper into the findings that our Professor Peter Gishangi, who has been the principal investigator, has summarized for us. Thereafter, after this panel discussion, we shall have an opportunity, again, with the audience, if there were matters that might need some responses from the principal investigator, but that will be after the break. Now, looking at the findings, and this is a question to all the panelists. Are there results that surprised you or struck you as the most important? Perhaps we could start from the further end, Dr. Bernard Onyango. Anything surprising you saw in those results?
Thank you, Sam. I think by and large, I'd say what we've seen is actually a confirmation of the anecdotal evidence for what people have been thinking about these issues. Probably the one surprising thing was, the increase, the net gain in contraceptive use, given the talk about service delivery disruptions, which is not to say that there is no service delivery disruption. It's actually there, and the evidence have shown that. But I think importantly, it's about what the pandemic has done is really to amplify the interconnectedness of health and economic and social well-being. And this study really brings that out, showing in various domains. While COVID-19 was initially, a health issue, it is affecting our well-being. It's affecting our economic well-being. People are losing jobs. It's affecting other domains. And probably, I think one thing that I wanted to highlight, which this data does very well to bring out, and we talk about it, but there's usually very little data to actually say, okay, there's a problem. If on time used and how that, the gendered roles that we have actually favoring or disempowering girls, so to speak. And it was interesting that you can see from the time used, with the restrictions and people staying more at home, the girls are doing more work, for example. And even in this period when everyone is affected, you can see on the key things, the men are more likely to be in paid work over the period compared to the girls. And they're also more likely to be involved in schoolwork. So I think the data is just really amplifying some of these issues and really reminding us about why we need to disaggregate our analysis at various levels, including looking at these, what comes out, whether in health or in socioeconomic sector, through the gender lens. Thank you.
Wow, that is quite something. And I think we can pick up some of the things you say there. If you look at the uptake of contraceptives, one expected huge disruptions. But then when you go deeper into the data, you find that in the earlier months, perhaps March, April, when this thing, COVID, really hit us, there was a lot of fear, and the data there shows a decrease. But then after that, we see an increase, an increase. And perhaps that could be contributed by a number of circulars that, for example, the Council of Governors send out to the counties that we need continuity of health services. The Ministry of Health at national level also started emphasizing that we need essential health services to continue. And perhaps that could have also helped to see that leaders actually came out, say we need these services to continue. Thank you so much for that. Now, Gladys, anything surprising you saw from those results?
Thank you very much. Yes, there are many things that are surprising, but what I've picked out, given that our role has been to create awareness on COVID, and that we expect change, and that we expect the youth to be the ones helping us to change, what I picked was that youth and adolescents were the least compliant to the regulations that we have put in place, and also that some of them, about 50% of the women, are saying that they are not sure that somebody has been infected in their community, and that shows that they do not believe. So talking matters of COVID, I think we rely on youth, that's what we've been discussing, and saying they're the ones who will bring change because they have a future and they would like to make sure that everybody is taking the precautions. So I feel that is something surprising to me, and it's something worth discussing.
Wow, something to really follow on as we continue. Thank you, Gladys, for highlighting that. Now, Gladys started by saying the youth. And here we have one of our young people, Brian Otieno. What would you like to say about these results?
I think I'll concur with Gladys. One of the things that really surprised me was the risk factor that young people are really being exposed to. And it's clear that at least 14.7% from the study is that young people are already out there. And one of the things that I really liked was, not really liked, but came out is boys are more prone to going to see their partners than the girls. And so I was wondering if the girls are not being seen, they have a lower percentage of going out. Who are these boys going to see? Food for thought. Then the other thing that really came out clearly for me, it's mental health. Like the correlation between mental health, SRHR, and COVID. It is like, how do we look at it in terms of the interlink? Is mental health affecting uptake of service, especially among young people, or it's the other way around? Or does this service, or the service or uptake of SRHR or FP during this period was because of mental health, and are we expecting it to go down? So I think it's high time now we start thinking of like policies, or rather implementation, focusing on integration, approach towards FP and mental health, and how the various factors in place among young people's life might either impact or influence uptake of FP services. Because mental health basically is behavior among young people, and that's behavior. Like behavior is what leads young people to probably have uptake, low uptake, or high uptake. Yeah, thank you.
Sure, thank you, Brian. So Brian mentioned there something which is very interesting, that we are seeing young people, the young men going out for the partners, and then in the results, we see the young women is not as high. So he was asking, who do these young people go to meet? You know, that's a question Brian was alluding there. And a very important thing, mental health. Interestingly, from the studies, you'll find that when it comes to the source of psychosocial support, many said they get it from their mothers and their friends. And I was asking myself, where are the dads? Maybe Bernard will tell us where are the dads here. And where are the other institutions? Yes, so we are here now. Anything surprising, Dr. Wanjama, from those results?
Thank you very much. I'm very, very happy about this research, and particularly disaggregating data in form of gender. I get the first panelist that the issues of gender are no longer hidden. They are out there. And what we are saying is that men and women, boys and girls, young women and young men are affected differently. Wherever or whatever happens, they get differential impact. And therefore, even COVID-19 has created that girls have been affected differently in almost all these areas, and to the worst. And therefore, as we address the policies, we need to take major interest in how to deal with the issues that have been exposed from a boys, a girls perspective. We can no longer hide our heads in the sand and say the youth. There is nothing like the youth. The youth are young girls, the youth are young boys. And therefore, what was surprising for me when I read through your 9 slides, I thought the disparities were higher than they are being expressed. For example, in the form of observing the stay at home, I thought I would get like 20% differences between young men and young women. And therefore, I'm happy that the disparities are not major, and therefore can be addressed very, very with the issues, knowing that we are not yet there, but advantages and disadvantages when it comes to incomes, you have heard women are disadvantaged, and that is all through. Young girls are disadvantaged. When it comes to employment, well, young men have employment even during this time of crisis and therefore have sources of money. Young girls are not in employment. Unfortunately, the time use, they're using a lot of their time taking care of their households, their families, etc. Why don't we also look at how can we quantify care and caregiving so that we know girls are giving care and therefore this is what it is costing them, because quantifying that will help us also look at the contributions of women who are also who used to be girls as far as the economy is concerned, and quantify that.
Wow, thank you so much, Dr. Wanjama. Very pertinent observations there. I also noted that intimate partner violence among young people just post-COVID, specific to COVID alone, was 43% since COVID. 43%. That is something, when you are having figures in 40s, like you're saying half, those who do statistics will tell you of the margin of errors and all that, and you find that those figures are alarming, something that really need a discussion. And therefore, looking at these findings, you can have quite many findings, but some are actionable and others might know. So with these findings, are there some actionable findings? An area that you think, yeah, here we can have an action. We can do this or do that. And we want to hear from you, Dr. Bernard Onyango. Anything that's actionable from those results?
So I think just to start, the part of the action is what we are having here. And what we are having here has to be extended beyond this room, and that is the communication. I think the findings are very rich and very informative, and what we need to do as part of the action is to make sure it reaches the right people who will take the further action to implement. For example, one of the things that pops out, when we're looking at service disruption, one of the main factors actually leading to people not accessing services was about the individuals themselves having the fear that they're going to be exposed to COVID if they go to health facilities. As we know, for example, right now in Kenya, it's like we have a second wave. We remember initially when COVID-19 started out in the country, people were very fearful. And then as the numbers went down, perspectives sort of changed and people decided to live their lives normally again. But with this second wave again, we are seeing a bit of fear. I think everyone saw the other day the clip that was going around of somebody who passed on in the matatu. We don't know the cause of death, but it was being alluded to as being COVID. And so part of that communication really needs to be about how are we ensuring in our health facilities that we minimize your exposure to COVID-19. So that's really one of the things I see. But very importantly, I think the information coming out of this needs to go to the different actors, be it your MCAs in Nairobi, because a lot of people are just talking about COVID this, COVID that, and we don't really have the numbers or the data that is supporting the response. And so what we are seeing here is something about the response. We've also had trying to reach to people through digital platforms, okay? And again, we see that reaching people through digital platforms is not enough. Number one, not everybody has access to those digital platforms, computers, mobile phones that have access to internet. But also there we are seeing that there is a gender divide. In fact, a significant gender divide. And so in terms of response on how to reach out to the communities, we need to think beyond, yes, we need to leverage digital platforms, but also acknowledge that they have limitations. And so what do we do beyond those digital platforms? So I'll leave it at that for now, and probably leave my colleagues to also say something on what they see as immediately actionable. Thank you.
All right, thank you, Bernard, for bringing up that aspect, things that we can act. And remember, Nairobi, among all the counties, the data shows that we are leading in the cases. And therefore, trying to also have these findings that look at these young people, it's very, very, very important. And it can also inform what can also be done even elsewhere. So, Gladys, anything actionable from those findings that you think this one we can act on?
Yes, from what he has said, we need to communicate, and we need to be innovative so that we can use this opportunity to deal with the issues that are affecting the youth. We need to engage youth themselves in communication. So if youth can use the technologies that we are talking about, and knowing that our youth are on social media most of the time, we'd rather engage them to use that social media to change behavior by communicating messages that we can work on together with the county government and ensure that they target the issues that are affecting them. In this communication, we have noted that the problem is that people do not know how to do certain things. So we can engage them so that they know how to do that. On the other hand, one other actionable thing is to ensure that for us to continue with the essential health services, we'll need to also continue engaging the health workers and making youth to be close to these health workers so that they're able to share information, and whenever they need help, they can be able to reach them and get the help they need. So we need to look at those barriers, look at this issue of idleness. Our youth are idle, and that is what came out in the study. And if they are idle, then we need to be innovative and use them to do the communication. Because that's what I said earlier, we are depending on the youth to help us pass the information to their peers, and it's easy for them to do that. The other thing is, as we are dealing with the idleness, we've seen that the parents are supposed to be providing support, psychosocial support. They also need skills to help these youth to change behavior. Because we are seeing that the parents are there, they are there to provide the support, but the youth are still having the depression and all that. It means there's something lacking, that we may need to engage parents also so that they know how to deal with these youth in terms of engaging them, ensuring they know what they are doing, and also supporting them in all the health needs that they may require. Though what we know when we talk about reproductive health, it's rare that children will go to their parents to discuss these issues and get help from them. So we need to look for innovative ways of ensuring that their youth who are empowered and they are able to help their peers to live the right life and also to know where to get services whenever they require them.
Thank you so much, Gladys Mugambi, for that. And Gladys has brought up one issue, the role of parents. And she has emphasized how that is important to really support the young people also. But somebody was also asking that the COVID-19 situation has also affected parents. Maybe if we have another study of parents, maybe you can ask now who should help who, you know, and all that. Maybe some of it could also be, you know, it's great. And the African Response, the youth, was also looking at even the home situation, how it looks like. And that can just tell you also the stresses that parents might be having. But a very good point highlighted there by Gladys Mugambi. Now, the youth, everybody is talking about you. What action from the voices of the young people? Are there any actionable things from the findings?
Yeah, before I got the actionable points, the other day someone asked, why are youths not really putting on masks? Then someone from the other room just asked, kama condom umeshindwa kuvaa, mask watavaa. So I'm looking at this data, and it's really disapproving that there's already uptake of service. Like condom use among young people has increased, especially after COVID. So for me, the most immediate action to me is how do we make this data palatable to young people? Because let's just be honest. Young people and numbers, whatever has been presented today, you go to the community and upe youth kwa mtaa, these are jargons. Like these are just words and numbers of 50% or 47.5%. Like I think it's now let's take this data to the young people. Like let's communicate to the young people and reanalyze it. Is it something that's it's happening? She said that probably the numbers on gender disparities are underrated. So are these things that we can also as well go to the committee and recheck on that, because these numbers, it's one thing to have data, and it's another to have young people agree that enyewe indo stuff inafanyika mtaani, or this is what is really happening to us. So I think the most immediate thing is how can we make this data more palatable to young people, for them to be able to consume and like relate to it. From that, I believe we are going to find the best innovations, as Gladys has said, and solutions coming from the young people, because if the problem is with us, then I think the solution is still with us. Yeah. So the other thing is the issue of cost and access to services. I think we need to start really looking on investing in community health systems, because the most immediate service I can access as a young person. For instance, nimekuwa na dem jana and I feel like I kind of missed. The first place I would want to go and access that service is the pharmacy. And these are community health systems. This is the closest facility I can access service to. So I feel like it's important we give more attention and investment in community health system, because this is where the young people are. Nitalipa fare kwenda tao kuja kuchukua P2 ama nitatafuta food. No. Like our priorities are changing after COVID, because most of us, let's say we are not employed, we don't have jobs. Accessing these ICRHK services are maybe becoming more costly, because the community health systems are not really working for us well, or they might not even have commodities that we need in the community. So I think with this data, it's just evident that let's again stream down the community and invest in the families, giving information, and PFA is one of it in terms of the social support systems. Just have parents understand that these services are important for young people. How do we bring conversations or dialogues between healthcare providers and young people? Let's say community gatekeepers and young people. So this data in itself speaks a lot of volume, like speaks volume in terms of our next steps in reaching out to young people. And I believe this cannot be done if young people are not part of it from the onset. Yes, we are here already, but still let's go back in the community and have young people just look at this data and understand that yes, yeah, thank you.
All right, thank you, Brian. And before we get to Dr. Wanjama, you mentioned something that I want to get back to Gladys Mugambi. You are looking at young people as also consumers of this data, not just the policymakers who need to put up some actions, you know? How are you now, from where you sit, handling matters of health promotion? How can some of these findings also speak to the young people? how can the Ministry of Health also speak to the young people around these matters?
Thank you. That question is actually one of the areas that we really need to strengthen. If we have to communicate, we must have a system for communication. And most of the times, we are focusing on maybe using media, TV and radio. We know youth are in social media, but also we can go further and engage them. Face-to-face engagement, so that they can ask questions and they can be answered. Unless the communication is two-way and the system is good enough, it will be very difficult for us to engage them as much as we could. So we need to strengthen those systems, come close to the youth, and let them, as he has said, guide us and help us to understand how best we can communicate to them, especially the youth in Nairobi. There must be networks which exist. So we need to get all these networks and see that we are able to send messages and get feedback, and then we are able to act on the feedback so that we can help our youth to understand the data and what it means. So that is a very important component, the communication channels, and ensuring that we have a relationship.
Great, thank you, Gladys. And we shall be getting back to you sometime later. That even technology, we know that young people, it's always assumed they will be very technology savvy, they will have the gadgets, they will do what. But there could be also barriers that the fundings are saying around that. There are also barriers around technology and even the privacy. And we shall be coming back to you to speak a little bit more on that. Now, Dr. Wanjama, any actionable items from the findings?
I see the findings very appropriate and actionable at every level. But I'm looking at that from the institution of higher learning, like the universities, that although they will be spreading the information to the category that is the higher institution, I think this information, this research findings should be disseminated to the universities. Get their structures, the student body. If you got the student body with this information and mandate them to come up with what they think are the policy issues, what they think are the program issues, what they think are the issues that should be taken at the family level, because at this research has given us information that can be acted at the family level, at institutional level. If I come to the area of the family, we have just said that social support is very key, and mothers are giving major social support. How can we bring the fathers in? I know the young men said they consult with their fathers, but that was only 22%, meaning that over 70% don't consult with their fathers. So who are they consulting with? How can we bring fathers in? How can we also bring families in to share responsibilities in the family? So long as we continue to say, yes, care work is for women, we'll still end up in this quagmire, where when it is emergencies, women and girls are locked into their houses and they continue to give care work, and nobody thinks they are doing anything because care work has never been taken as any valuable input. Is there anything that we can take with this information? Can we take this at the family level and start saying, can we share responsibilities? Because that can add up some of the mental health issues that we are seeing, that instead of young men suffering because they are idle, that they could be busy at the household level. And then when they share work at the household level, love is spread. People start speaking like a family, and they start speaking and sharing even resources. So that is one area, institutions and the family. However, I'm also saying that all this requires resources. To action requires resources. If we say engage the youth, the youth need to be facilitated to engage. So our government and our health ministry, how can we start distributing resources so that with resources we can say do communication. With resources we can say enhance technology. With resources. So I'm saying that so long as we do not touch on issues of redistribution of resources, so that what is up there can also reach the grassroots, so that the youth can be facilitated to meet and share, to meet and strategize, to meet and come up with their own policies to solve these issues. Yeah.
All right, thank you, Dr. Wanjama. And I will not leave you still before we get back to our other panelists. You know, when you talk about intimate partner among young people, I'm sure people are wondering. Some might even be wondering, does it apply? But we are talking about young people up to the age of 29 years. So some have their partners. And we are seeing, since COVID, 43%. So from where you sit, the Center of Gender Studies, how can, what interventions can be done to support these young people, especially when it comes to this intimate partner in this COVID-19 scenario? Any specific actions now? Any specific actions that can be done? Because this is not good data.
Yes, I was waiting for that question 9 because I know you are supposed to come to question 9
yes.
that deals with SGBV,
yes.
gender-based violence, and intimate partner. However, I can deal with it now.
Sure, yes.
Now, intimate partner violence is a very silent issue. It is a huge issue because if you define violence as any act that disrespects the partner, it could be physical, it could be psychological, it could be physiological. I mean, any act that dehumanizes the other partner. As far as this group is concerned, intimate partner violence has been taken up from their own families, from their own community, from their wherever they, and I'm talking from this, from the perspective that a lot of students in our institutions of higher learning have complained of intimate partner violence. So it is huge. It's a huge problem. Why is it huge? One, because people assume violation is normal. That if I insult my partner, that is normal. If I keep quiet from my partner, that is normal. But it is not normal. It is violence. And what we need to do is go to the roots. Where did the rain start beating? So that the intimate partner relationship is very high. It's because we grew being told women are second-class citizens, women can be beaten, women can be insulted. When you are idle and she asks for money, you think she is demeaning you, and if you don't have the money, the best result is to be violent, because once you are violent, she'll leave you alone, and therefore you will escape being asked for sukuma wiki money for that day. And this is irrespective whether the young partner or another partner. So what I'm saying is we need to go to the roots. How can we stop intimate partner violence? We need to go to the youth. We need to go to our families. We need to go to our communities. And in this perspective, I'm asking, can we start with our cultural leaders and our youth leaders and our religious leaders, sensitize them that it is wrong? to violate your partner. And let them spread that. Once they see it is wrong at the community level, then we may start seeing people going against intimate partner relationship, violence. But unless people agree it is wrong, and that even if you look at me badly, that is wrong, you're dehumanizing me, and we define what intimate partner violence is, we will never hit this. However, my consolation, we have Nyumba Kumi, we have youth groups. If we start small in these youth groups and sensitize, create awareness, and let them see it is wrong, then we might grow seeds of what intimate partner relationship that has been normalized that could be dealt with from the grassroots. And that is the only way for me we will ever deal with the intimate partner relationship. When I grew up, we used to uphold people men who fought would say, I beat her last night, and people are happy. I mean, people did not see anything wrong. Today, if Professor ICRHK would stand here and say, I beat my wife, we all look at her and he might say, are you mad? Because we have started seeing it wrong. That's what we wanted to see. Starting from home. I'll just stop. As I stop, I'll give one example, which has made me know we will deal with the intimate partner violence, but it has to be rooted from our own cultural perspective. I have this family that is close to a place. And I remember this man was like a role model in the village. We have never had any fight in that area. And then his son married. And I think within the first 1 year, he beat the wife in his compound, in the father's compound. The father called the son and said, have you ever heard me? Have you ever heard me when insult your mother? And he said, no. So what gives you permission to beat your wife? I'm setting you out of this compound from now. Henceforth, go out there until until you get to appreciate that your wife, like your mother, are human beings with dignity, respect, and should be. And in this compound, you will never emit any violence. And he was sent out. When you are ready to come back repentant that you never do that again. And it is only when you come and tell me you never do that again. And that family is a happy family. Never again. So we needed to get never again. By people being convinced, not being told it is bad. Thank you.
So Dr. just said we need to get the never again. But she's told us we need to go to the community. We need to go to the grassroots. The question is, who needs to go there? What needs to be done? You know, from a policy perspective, from an intervention perspective, what needs to happen? And I'm looking at Bernard here, looking at moving data to action. You know, what is this? How do we get there? That we have a man like the one she has just said in the story, becoming not something anecdotal, but a common feature, a common value system. How do we get there from a policy and action, big picture, and then let's get to the micro.
Thank you. So I think, a lot has been said about, communication, but what we need to also talk about is segmenting the audience. And we've talked about, like the result we are seeing here. We can have action at, various levels, and you can only do this if you segment your audience and package the information in a way that people will be able to take action from the different levels. For example, one thing that, and this is enshrined in the Constitution, by the way, is this issue about public participation. How do we use information coming out of research such as this to inform public participation, which includes the resource allocation. Whether you're thinking of it at the National Assembly level, there's actually a mechanism for that, but there is that mechanism all the way to the award level. How do the MCs make those decisions about where they're putting resources? And it behoves us and I'm sure if I challenge the people in this room today and say, can you lift up your hand and say, since the Constitution 2010, have you ever been involved in the public participation mechanisms? There are very few of us, and yet we have the information. So it doesn't help that we have information and we are not using it towards influencing public policy and programming at various levels. And for me, that's something that just came to mind. But there's also the lessons we are learning from the response we've seen. As we know, the COVID pandemic it's an evolving situation. As we see right now, we could be going to another phase of it, and we don't know how it's going to pan out by January or by the time we'll eventually get to have vaccines. But I think what was clear at the beginning, response, public policy programming response was sort of not entirely informed by evidence, and that's okay because it was something new. But even then, I think we could still strengthen. I think this gives us an opportunity to think about how do we package our information and how do we do targeting to respond to issues such as this. And so for a country where we know that the social protection systems are still quite weak and investments are still quite weak, what have we learned from this episode, and how can we pick some of the information coming out of research such as this and related ones that can inform the kind of social protection responses the government is actually putting in place to mitigate the socioeconomic impacts of COVID-19. The other thing I wanted to bring up again, just to point out again, because I had put this down on public participation. Right now, we have public participation on the national population policy that's being led by NCPD, and they've been moving from county to county. And it's worthwhile thinking whether some of this information we are getting here can inform that process, and for us to be able to take part in that. So there's public fora for doing that, but there's also more or less like private or institutional memoranda that can actually be sent to inform this process. So the gentleman in the panel talked about whether this, even as much as we are taking our efforts to disseminate research findings, whether we are speaking to the audience in a language they understand. And I think it's an evolving issue. It's something we are aware of as researchers, and we need to do better. I think today, as you are walking around, this room, I think that kind of thing is what you're talking about, unpacking the information. So I've seen there's some sort of cartoons and information that at times might be, it needs to be tested though, but it might be more impactful actually in calling to attention young people. I don't know, for example, how many of you have interacted. I know a lot of young people interacted with this comic strip, the Shuja's comic strip, and they have communication through that, and they've expanded sort of their reach. And so it's really trying to look at all these other new platforms or new ways of thinking, and really planning. We must have, for all researchers, really we have to have a communication plan. And it can't come at the back end. It really has to come at the beginning of of your research process. Think about whom do I really want to target with the information that will come out of here. And once I segment my audience, how am I going to reach them? What are the different platforms that I can use to reach them, whether it's stakeholder engagement like you have here, and so forth. One last thing I think I'll say is we have to reach out, move out of sort of our silos. I go to a lot of these meetings, and you know, we are very happy to be a community. We are a community here. But we have to move beyond our community and reach out to those. As I said, the COVID pandemic has really shown us interconnectedness. So this is not just about, it's not just a health issue. It's an economic issue. It's the other social aspects. Whom do we need to involve? It's not, and I've had people, you know, challenge Ministry of Health today about, for example, resources. COVID is way beyond Ministry of Health, and we have to, you know, we have to reach out to other key stakeholders who Ministry of Health and other players can work with in order to take immediate action. But more importantly, there are going to be, we have to keep our minds on the long-term implications of COVID, something probably that didn't come out of this study, but it's very clearly, understandably, because most of the kids were out of school anyway, so we didn't know what was going to happen. But you can imagine we are likely to have significant dropout of the school system because of this disruption in education. And it's going to be one of the key challenges to make sure that let's try to get back as many as possible of those school kids who are supposed to resume, because if we are not careful, we are going to lose very many of them. Thank you.
All right, thank you so much for some of those things that we need to do to move this discussion forward. And you talked about stakeholders, and one of the key stakeholders, the young people. And therefore, Brian, I would like to ask you, how can we encourage youth to meet their health needs? What should messaging look like? You know, that even where Gladys is sitting, I said, this is what the young people are also thinking about. Okay.
So for me, I think we're already trying. Like from my perspective, I would say the organizations or stakeholders who are already working with young people or youth focused, there's something already being done. However, I like what Doc mentioned, that our culture is again a hindrance to how we access service. I think as young people, we've been brought up with the notion that our African parents, let me call them our African parents, are so much on giving instructions more than directions. And that's the problem with our messaging. So our messagings are more directed towards giving instructions. Young people should go seek healthcare facilities, or young people should use FPs. But what if I'm not ready to use the FP? What if I'm not ready to use condom? You see, there's that need to also give direction or reasons, for instance, because young people are we are experimenters. We want to explore. Ile kenye utaniambia, I'll do the opposite. It's because it's more of full of instructions, like nikitoka hapa nipate umosha vyombo, nipate umepanguza nyumba. That's how we were, like that's what happens. And the same communication method is being used in the form of communication that we give to young people. Most of it is just instructions on what young people should do, but we're not really getting like what young people need to do or understand from the communication they're getting. So I think we've just picked that cultural aspect of being instructed to our communication means and methods, how we're going to do them. I think the other thing is the messaging, or rather what will really work for young people is, I believe as a young person, innovation is us and we are creativity. Like I like what Benson mentioned, like if you get into this room, like there's just the attraction of how these pictures are. Something being done by a young person. Like you wouldn't avoid to go and just look at that picture in itself. You wouldn't avoid, like you just get in, the first thing that will strike your mind is the whole painting. Like working with young people in itself is a way of coming to provide innovations that will work for them and provide the solutions for them. And looking at the data in terms of communication, we have to also keep in mind that young people are not homogeneous. Let's just remember that. We are not homogeneous, because, for instance, I'll take an example on the autonomy and privacy. The same situation of sharing a room, a one single room, in informal settlement in Korogocho or Dandora might not really apply for a young person in Runda. But they still have the issue of autonomy because my phone has been taken away from me. It's still autonomy, but it's still applying in terms of privacy. Like my mother wants to know where I'm going all the time, or they want to know what time I'm coming back home. That applies in Runda. But when you come to coach, it's about the space. So when we do these communications, we have to consider the fact that, yes, they are all young people. We are all young people, but our issues may differ depending on either location, geography, age, because we have different needs and different capacities of probably understanding the message you're giving us. And the good thing is that the research that's coming out is, let's say, 16 to 24 years, which is a very long range. And this is why young people, I think, I understand from my perspective as a young person, how many of you have heard the word kuomoka? It's one of the things that has been going around. Kuomoka. So I think for young people, the two definitions that I believe from my perspective is, one is we are defined by how we define success. COVID came and took away our success. We felt like we were having dreams and we were having gigs and I was about to finish Form 4 and I'm out there. That success that was snatched from me. And these are the things that are really causing the mental health issues among young people. And the other thing is young people want to belong. Young people want to fit in. And fitting in basically for young people is one of the most common things. For young people, I think communication in terms of just looking at these two aspects for young people, like how would health uptaking behavior be associated with the two things, like belonging and also feeling like your success or your future is triggered towards you being healthy. So I think just look at what interests young people and then rely on that to bring out the communication clearly. So thank you.
All right, and since we are getting into our wrapping up time, we are getting into wrap up. We have a few minutes just remaining. I think we should be wrapping up right now. So I just want us to talk to Gladys, just in under a minute. What is this in health promotion that you can do around this messaging? Maybe even 30 seconds as you wrap up.
Thank you. Yes, as the youth are saying, we will use technologies, we'll use artists, we'll use what they like and engage them so that they tell us what is it that they like, and then we are able to engage with them and use that to communicate with them. So
thank you so much, and we want to thank our panelists, those who are many ideas coming from these findings, and we want to thank our researchers for giving us something to not only talk about, but actions that we can look at. So I want to invite back my co-moderator, Benta Owino.
Asante sana, Sam Mulianga, for a very incisive session on interpreting the findings of this data that has been presented to us this morning. And thank you very much, panelists, for your policy and programmatic recommendations. Thank you, Brian, for speaking to us in the language that youth best understand. So thank you very much. This session, as I have said, has been very incisive. We have been able to interpret the percentages and what it means at an individual level and at policy level by government, national and county governments on what can be done to address the impacts of COVID on young people. Taking the example of Nairobi metropolitan area. So, in summary, whereas there have been positive outcomes, especially for contraceptive use, there are concerning issues around gender-based violence, youth compliance with public health measures to prevent COVID. There are concerns with mental health and the social support that's available to youth. And those are important issues that as we come out of this meeting today, we need to, in our various dockets, take up to ensure a well-rounded and healthy and economically empowered youth. Overall, youth take responsibility. Government partners take responsibility to assure there is a reduction of the negative impacts. I want to once again thank you for coming to this meeting this morning to understand the research findings that were organized by the ICRHK through the PMA project, and with the guidance of the Ministry of Health, the Kenya National Bureau of Statistics, the National Council for Population and Development, the Nairobi Metropolitan Services, and the universities and other partners are based even at the community level, and the youth associations who are part of this exercise. Professor Gishangi, thank you very much for steering the process and for helping us to compare the time before COVID and what has been occasioned by COVID in the country. As we leave this morning, or is it afternoon yet, I want to remind each and every one of us, continue to mask, wash your hands, sanitize, and distance. That's part of our responsibility to ourselves and in helping youth to comply with the public health measures. Asanteni sana na siku njema. That's the end of our session today. Once more.
This is NTV.
Beat sensitivity pain fast with Sensodyne Rapid Action for clinically proven relief in 60 seconds.
We'll take nothing for granted and always remember to taste the simple joys. Enjoy the magic of Christmas with Coca-Cola.
Oh my, oh my, oh my days. Life is wonderful. Life is wonderful. Life is wonderful. Life is wonderful. Never understood. Life can be this good.
Our products range from bags, folders, wallets, menus, desk sets, travel bags, laptop bags, and many more. At Leather Masters, we have an excellent turnaround time and deliver products according to agreed specification and time frame. Introducing Ushindi Cream Bar Soap. It foams well, is gentle on skin and hands, and cleans your clothes and dishes well too. Available in 1 kilogram and 800-gram bars and 175-gram tablets. Also available in all your favorite variants. Ushindi, a quality product from Pwani Oils.
Did you know at Ruiru Mabati Factory you can open an account and lipa pole pole at your convenience? Did you know at Ruiru Mabati Factory you can get customized sizes according to your roof plan to avoid wastage? Did you know Ruiru Mabati Factory offers free delivery countrywide within 72 hours?
To order, call us now on 0111 050 700. Ruiru Mabati Factory, Mali Safi kwa bei.
The full house this season when the family comes together.
To reconnect.
One thing we do, we watch GoTV. We love it.
Is everyone's favorite place this festive season.
Usimiss out. Get GoTV decoder kwa shilingi 1999.
GoTV. Love it.
When the world changed, it made us go back to the simple joys and love the little things even more. Like serving up your best, eating together, and sharing more. Now, we'll take nothing for granted and always remember to taste the simple joys.
Enjoy the magic of Christmas with Coca-Cola.
Rock Plastic Tips. Rock plastics are made with 100% virgin raw material. Rock plastics come with new and different unique designs.
Rock Industries brings you rock plastic with a variety of kitchenware, ranging from kitchen dishes, cups, plates, clothesline pegs, spoons, and even rulers for learners. These and more products, contact our offices on 0722 575619 or 0736 028181.
Welcome to Good Life, where we are all about you. And when we say you, we mean all of you, including the little ones. We're all about ensuring you feel better and healthier, so you enjoy every moment with the ones closest to you. A smile on your face is what we're about. That's why you'll always be welcome back to Good Life pharmacies across Kenya with the same smile on every visit. Good Life. We're all about you.
Oya cheki, kuna vile sasa muziki manze, kuna vile inajipa manze, yani na cheki haimaanishi tu tunajibamba, yani very regular.
Kitu ya muhimu kwanza ni kujua hali yako ya status ya HIV.
Kwa hapa hivi tuwapeleke na Rieng, tujue venye manze tutasaidiana si kama vijana. Na kama unaogopa kwenda pale hivi kwa clinic, unaweza pitia pale hivi kwa chemist ya mtaa, uitishe a self test kit na wanauza 500 bob only. Unajitestia tu mtaani, unajua hali yako.
Manze na ukiweza patikana nayo, yani uko positive manze, usiogope. Kuna madawa yani jo, kuna counseling manze, unaweza kula fit yani, alafu unaweza piga bado ma exercises kiasi hivi. Na kama nyewe manze ukiweza patikana yani hauna manze, usiasie tu unaenda kutafuta tena.
Cheki. Ukiweza abstain.
Lakini maji yakizidi unga,
wrap it before you tap it.
La bila gloves haiwezi.
Unapoendelea kujikinga kutokana na HIV, tafadhali zingatia taratibu zote za serikali za kujikinga na virusi vya corona.
Afya bora, maisha bora. Jipime, jiinue.
Kila siku unapokaza mshipi, unapozidi bidii, unapoongeza maarifa ya kuimarisha maisha, unapoongeza nguvu ya kukusongeza mbele, unaposherehekea na kuwakaribisha wengine kufurahia nawe, unapojijenga kibiashara na kuonyesha penzi lako, unga unaozaidisha uko papo hapo, kuzaidisha utamu wa maisha kwa kila namna, kila mara.
Familia ya Ajab imeongezeka ili uzidishe mapishi.
Mambo ni Ajab.
We'll take nothing for granted and always remember to taste the simple joys.
Enjoy the magic of Christmas with Coca-Cola.
We provide retirement savings solutions for everyone. Our products include statutory deductions, additional voluntary contributions, gratuity management, lap fund amal, Sharia-compliant product, Imarisha, and diaspora retirement savings plan. For more information, visit our website at www.lapfund.or.ke. Lapfund. Work, save, retire.